Hello, and welcome to eviCore Healthcare's educational webinar series. My name is Jonathan Murray, and I'm eviCore's Senior Vice President of Growth and Innovation for Seamless Solutions. If you would like to learn more about eviCore and how we enable better outcomes for patients, providers, and health plans, please respond with a request for more information in the survey that you will receive at the end of this webinar. Throughout 2020, eviCore will host free educational webinars that include guest speakers, as well as eviCore subject matter experts to discuss today's most pressing healthcare topics. And now, it is my privilege to introduce you to Dr. Eric Gratias, the Chief Medical Officer of eviCore Healthcare. He oversees the company's formulation and maintenance of clinical guidelines, as well as its payer and provider relations, utilization and quality management services, and health services research. Dr. Gratias also serves as the Senior Clinical Liaison to eviCore Health Plan clients and the broader physician community. Before we begin, just a quick reminder to please submit your questions using the question option within WebEx. This presentation will be recorded, and it will be available on demand located on the Insight page at eviCore.com. Take it away, Dr. Gratias.
Thanks, Jonathan, and welcome everyone. Thanks for all the interest in today's topic. As Jonathan said, I'm Chief Medical Officer at eviCore. I've been with the company 7 years, and I've worn a number of different hats and have been Chief Medical Officer now for about 9 months, and really enjoying the role and getting a chance to interact with a broader audience more often. And so this is we're at a really critical time. I just want to, level set, what we're going to try to get through today. We have a lot we could talk about with prior authorization. It's such a hot topic. So we're going to spend a little time just talking about, why do we have it in the first place? Because there's a lot of people that question that. So we're going to talk a little bit about why it's there. And we're also going to talk about why it needs to be different than it is today. And then we're going to get a little bit more specific with you about the ways in which we are working to evolve prior authorization so that we can preserve the solutions that prior authorization has brought to the market, but delivered in a way that meets the needs of today and the future. And we're going to talk specifically about using some advanced analytics and artificial intelligence tools, enhancing the use of a clinical decision support mechanism, and also looking, what a lot of you are here to hear about is how are we going to make the administrative burden less and easier to manage. So why does it exist in the first place? Quite simply, it's because healthcare is getting very expensive. And it's been expensive for a long time. And, we're getting at a place where you can't hardly go a day without having a conversation with somebody about how much healthcare costs, whether it's the system, whether it's out of pocket, whether it's deductibles, whether it's at the same time, we have practices saying, yeah, I hear all that, it's getting more costly, but my margins are shrinking and I'm having trouble making ends meet. So, the hospitals are saying we can't make ends meet, but their markups are huge. Manufacturers of devices and drugs are saying, innovation's getting more expensive to generate, so our prices have to be more expensive. So it's this kind of finger pointing game, and one of the tools we have to contain it is to look at utilization. The other thing that's happening, which is a good thing for our country and for the world, is that innovation is getting faster, and we're learning more faster. And I don't have to tell anybody on this call, just look at the information tsunami we've been living in since the beginning of March with SARS-CoV-2 and COVID-19, just to see what kind of information overload our system can produce in a relatively short period of time. So what's happening with spending? So, CMS is a pretty good projection. I mean, they're not perfect, obviously, but their data source is as good as many out there. And this was from their 2017 projections. So you can see we're not on a sustainable trend. Just to put this in perspective, if we hit that 5.7 trillion in 2026, that's about a third of our gross domestic product. And that's the point at which society starts to break down a little. I'm not trying to sound alarmist at all, but once you're spending that big of a bucket on healthcare, all of a sudden you're losing money for stuff like roads and local governments and police and schools and utilities and the Postal Service. So that some of that critical infrastructure that happened, that we're dependent on, starts to erode, or taxes have to go up to pay for the difference. There's only two choices there. And one of the ways Medicare is handling some of this is they're trying to flatten this curve by pushing more services into the Medicare Advantage pool, where there's more thoughtful management around cost, which for a lot of folks leads to more prior authorization. So the spending is real. It's not getting better. None of us on this call can fix it by ourselves. It's going to require everybody playing ball to fix that. But just that's where this comes from. So, and along with this, sorry, did I didn't skip. Adherence to evidence remains suboptimal. So we thought we had a really good answer as a physician community to prior authorization back in 2012 and 2013, when the professional societies all got together and said, look, we get it. This is a big problem. All of us as physicians, we want to do the right thing. We're not getting out of bed trying to profiteer off the system or make bad decisions or make irresponsible decisions, which everyone agrees with, frankly. And so we're going to take a look hard at our own specialty areas, and we're going to say, here are some services that we see from the data that people are engaging in that are just little to no value, and they should stop right away. And it was really an impressive display of guidelines that came out. And some societies took two bites at the apple. They did a 2013 publication and a 2014 publication. And we've had others that have just come out again recently, so they're still trying to do it. But unfortunately, that is just not showing up in the real world. So we're far enough out from that now where there's starting to be studies published on, hey, did choosing wisely work? Are people adhering? So here's a really common one that we see all the time. PET scans for routine surveillance. That was a target. It was a target from the American Society of Clinical Oncology. You just shouldn't do that. Yet, a year after that, almost 40% of physicians still use PET on more than half of their patients, and our own authorization data bears that out today. That we still see a very high rate of requests for that, and it's personal preference, and the people just didn't choose to align with choosing wisely. So that was a great step, but didn't get it done. We were, people that do work like we do took those recommendations and have tried to operationalize them to try to be another ways to help with adherence. Now, again, that means 60% of physicians are following it. Okay, so again, majority of you are doing it right, but still, there's a big segment of our peers out there who are not adhering to evidence where they should. So let's talk about why that might be. Because like I said before, this isn't about people are bad physicians or they have suspect motives or they're just trying to make money. They don't care about the patients. None of that is true. What is true is that physicians are busy people. Physicians care deeply about getting the care right for every patient, every time. And when something doesn't go right, whether it was your fault or not, you lose sleep over it, you don't eat well, the stress is unbelievable. We get it. We have more than 400 physicians employed by eviCore. We've all been there. Every single one of us has spent years in practice. We get it. We've been there. What's happening with the pace of innovation is that it's really getting faster, which is a good thing. Okay, innovation is critical. We have to keep up. But let me walk you through what's happened here. So this medical school dean that I've referenced at the bottom of the screen here, Dr. Denson, did a really simple but elegant study almost 10 years ago. And it was, the article was framed around medical education and how do we need to reframe our medical educational system to account for the digital age and the new pace of innovation. So he did a very simple study looking at the doubling time of medical knowledge using peer-reviewed publications as a proxy for it. So in 1950, the doubling time was 50 years. It was estimated at 50 years. So at that time, basically, you learned the majority of what you needed to take care of your patients through your practice life during your training. I mean, you could get a little ahead of some folks by by doing some CME along the way, but CME was really done more out of personal interest than really a professional need. So fast forward to 1980, that's down to 7 years. And those of you that have been around a little longer will remember that's about when the recertifications started to come up. Late 80s is when the American Board of Medical Specialties made recertification a requirement for everybody. And again, because the doubling time, all of a sudden you're several doubling times in a practice life, and your information and training has gotten pretty stale. So 2010, the year before we did the study, is down to 3.5 years. So think about that for a minute. That means that 50% of the medical knowledge of a person graduating in 2014 didn't exist when they started medical school in 2010. So that's crazy fast. So then he did what was really kind of blew me away, was he took it to the next 2020, projected it out to 2020, showing the same rate of growth. And if we were able to do live audience, I would ask for guesses from the group, but I have yet to have anybody quite get it. 2020, 73 days. Okay, COVID-19 has validated that. Okay, when you have that concerted effort, look at the information doubling time there. It's even faster, just because there's so many resources pushed on it. But so this is a good thing. But okay, start talking about medical knowledge doubling every 73 days, which means that the medical knowledge you need for your practice is also doubling. You don't have to know everything, but blind spots can creep in very, very quickly, and that's truly what they are, is blind spots. I've had them. Everyone has them, and everyone's are a little different. And again, it's less than half of what you see where you have blind spots, because everybody works really hard to stay caught up. But the truth of the matter is, things are moving too fast, and nobody can keep up anymore. And anyone that thinks that they are keeping up fully across their entire practice that's a blind spot for them, their ability to keep up. So here's a specific example. Last year, the National Comprehensive Cancer Network updated their guidelines 170 times across 54 cancer types. And also, along with that, the FDA introduced 18 brand new drugs and expanded indications for 28 others. So it's moving lightning fast, okay? So we know that's happening. Also, we're looking at the market, and this data is even aged a little bit now. But if we were to look at this again, I don't know that the rank ordering would be very different based on feedback we're getting. So what's one of the top payer pressures? Prior authorization, coverage denials, and peer-to-peer requests. They're all tied into this management of utilization and helping to adhere to evidence. So look, we hear you. We hear you. The way we have done it needs to change. Prior authorization needs to evolve. We got started in this because there was a slippage of evidence, and there was a slippage in cost. And one way to do that was to review cases and to say, let's find the ones that are not adhering to evidence and help get them steered to evidence, or confirm that there's really not a good evidence base because this patient is unique. However, we've been slow as an industry to innovate here. And it's just because things have been happening so quick. The easy thing to do is just to add more. And, I think we reached a tipping point as a system a couple of years ago where the cumulative administrative burden across all of prior authorization, and for transparency, I can't claim credit for all of the prior authorization from eviCore. We do a lot of prior authorization, but, you're experiencing it not just from us, but lots and lots of other health plans. And there are pieces within health plans that we have as clients where we do some of the prior auth and they do some of the prior auth. Everybody's trying to do it well. There's variance in ways people are going about solving it, and that creates additional burden because you have to think about who are we talking to and what's their rules and how do we do this, and we hear you. It needs to be better. So the thing is, we can do better, and we're starting to do better. We've been working on it all along, but we're really escalating our speed with which we're approaching this. So, we've heard you. You don't want to stop and go look somewhere else and get go open a website or go somewhere else to do something. You've hired staff, and a lot of you are staff who are hired because the physicians can't do it. So one of the ways we can make things better is to be in your workflow. When there's something that requires your input that today you'd have to send a message to the staff. You as a physician have to send the message to the staff. The staff has to then interact with the system, hit a stumbling block, and either go get the clinical information or stop and go back and ask the physician, was this okay? We want to get in the workflow and reduce all of those cycles of information, be in the system with you. We want to make it easier to do this, not harder. We want to provide data in a decision support model. We want to provide the data that you might have to spend looking up yourself. We want to get it into your workflow so that you don't have to stop what you're doing. And if you know you have a blind spot in a certain area, the tool can be right there. And we want it to be there. We want to help you when you need help with a decision, not after you've made a decision. It's a very, very different approach, and that's where we're heading. So, Jonathan, anything you want to add on that slide before we move on?
No, everything sounds great, Dr. Gratias.
Okay, great. So the industry's moving, and we're leading that change. We're one of the folks that are really pushing this because we want to do this better. So we're starting to really deploy some advanced analytics and really now getting into some artificial intelligence, as I mentioned before. And we're going to go deeper on each of these in the coming slides. Another tool, and that artificial intelligence really is saying, what can we learn about what's happened in the past and what's the likelihood that what's going to happen in the future with this particular request that's happening today. So we're sitting on a sea of data and we're trying to be smarter about how we use it. Clinical decision support. Some of our programs have been functioning that way for a long time from their foundation, and we've had really good success with helping to get to yes faster with fewer denials and fewer appeals and fewer peer-to-peers. And so that's another interim step we're taking is we're moving that strategy forward faster in some programs where we can really take some of the time to help process a case out of the system, particularly when the answer is a yes, or when there are multiple ways to go and the ordering physician has some flexibility in his or her approach. And if they just knew what was the preferred service for the particular health plan, they're happy to do it in this particular clinical setting, but they just don't know what it is. So in the absence of that knowledge, they go with what they would normally use. So having a clinical decision support tool that can provide that information at the time of decision speeds things up also. And also the tasks that are purely administrative. When you talk about submitting a prior authorization, I don't have to tell any of the administrative staff on this call, I know there are many of you here, you may be spending 3/4 of your time building the case, loading the patient, finding the provider's ID, checking the facility you want to use, stuff that it's really demographic and it's really housed in certain areas in the system already. And it becomes very repetitive, particularly when you have to come back in for the same patient. So we're working hard to automate some of those. So let's go a little deeper on the advanced analytics and artificial intelligence. So one of the things we've done today, and again, this is a form of clinical decision support, was to use clinical surveys. We're asking, in some cases, fairly detailed clinical questions that might be simple if we were speaking to the physician, but if it's somebody who's working on behalf of the physician, that question may not be as intuitive, and it may require a little bit more work to go get. So those clinical surveys, if there are a lot of questions or if they're very nuanced, can take some time to complete. And we've heard feedback that's been a source of strain for our physician partner offices, and we want to make that better. So we started to look at pattern analysis using our artificial intelligence and predict the likelihood that this request is just like one that's come before that we routinely approve for that physician. And this system is able to say, yes, there's a high degree of confidence that we're going to end up saying yes to this no matter what else we do. And so we've made the ability to issue an approval right then. So some of you may have seen that happening already. We've been deploying this in an incremental way already. in our radiology program. And, then taking those clinical surveys and converting those to internal tools. So rather than asking the physician's office to fill out these lengthy surveys, if the system is unable to generate that immediate approval, either based on the pattern or because it meets the pattern, but as part of our ongoing quality assurance, it was randomly selected for audit, so that we can continually verify the accuracy of that AI model. And we just simply are asking for records. If we upload the records, then we're taking it to our first level clinical reviewers, which are, depending on the program, might be nurses, genetic counselors, physical therapists, occupational therapists, a variety of others, who can then take that clinical information and do that work for you. And they're filling out the clinical surveys on our end, and if the survey leads to an approval based on the written records, it happens again very quickly. So it's it's a little bit longer to get to the yes, but it's less work for the physician office. And the ones that our first level reviewers can't approve based on the records, those are the ones that go to our physicians. And so we're overall we're trying to reduce the number of cases that are going to our physician review. So how does it really work? Okay. So we're leveraging our clinical data. So our clinical database is risen to over 140 million cases that we're using to train the algorithms. And so we feed that back, and we can get very granular and say, this physician specialty with this diagnosis and this procedure type and a variety of other things. What are the latest guidelines? What's been the recent shift and change? What are the specifics we can identify from the patient right away? What's the confidence score that this can be approved? And if it's got a high confidence score, the approval happens right away. And again, this is matter of seconds from submitting the case. And this is getting this right is very, very important to us. We don't feel like this is done. These, as I just mentioned, innovation changes. And so individuals' ability to keep pace with innovation in specific areas is variable. So this is an ongoing learning model, and we have a regular feed from our clinical decision pathways and system back into the AI model. So there's always a percentage of cases that the confidence score would say to approve, but it's randomly selected to run through the clinical review anyway to confirm the accuracy of that clinical model. And so we're constantly tweaking and tuning that so that we are getting out of the way administratively as often as is possible while still making sure that the patients are getting evidence-aligned care. Jonathan, anything you want to add deeper there?
Yeah, I would probably just add that, so we're getting really good at identifying those cases that have a really high confidence score, so we can get those approved very quickly. But then also direct those other cases where there's a lower confidence score, where our clinicians need to spend a little bit more time reviewing that case. And I think you're going to show this in a couple of slides, where the provider will then get a real-time approval or simply just be asked to upload the clinical information so we can spend more time reviewing it.
Great. Thanks, Jonathan. Okay, so this is where we're getting to today. This is an improved experience, and where we are in this step is we deployed this in our radiology program today, and it varies a little bit from we're working with our various health plan partners, and we're advancing the percentage of cases that are being run through this real-time decision approval or clinical record upload without running the pathways. We've been adding a step in an incremental way, increasing the percentage of our radiology cases that run through this. And we've been doing it gradually by design because we want to make sure that A, we're making the right decision, we're continuing to make the right decisions, and B, that we are solving the problems we think we're solving and not introducing new ones. So we've been deploying this incrementally over the course of the year, and many of our health plan partners have been really happy to participate with us, and we've been very appreciative of that. So it's allowed us to really escalate this further. We're going to get this tested in radiology because we went with radiology first because it's our highest volume program, so it was our greatest opportunity to reduce administrative burden. But our goal will be to take the lessons from radiology, from an optimized radiology model, and apply those in our other programs in descending order of frequency. And so we're going to take the biggest bites out of the administrative burden as we can in descending order, and we're going to work this through over time so that again we want to move fast enough that we're making a difference, but not so fast that we're making mistakes that are difficult to walk back. Anything more you want to say there, Jonathan?
No, just a quick time check. We've got about 15 minutes left.
Okay, great, thanks. Okay, so once we get to the clinical review, we're also doing some things to help make our reviews faster so your turnaround time is faster. So we're using technologies like natural language processing and optical character recognition to look at the records that are being sent and to extract keywords to help draw our reviewers to the key portions of the medical record more quickly. Any of you that know EHR outputs might know that, depending on the EHR template, you could be looking at a 20-page office note, and whether the key information we're looking for is on page 1 or page 17 could vary. So this OCR really speeds up our reviewers' time. It doesn't preclude them from looking at the whole record, and they do glance through for other things, but if they see the information they need to issue an approval, they can stop and issue the approval against our best clinical evidence. Because what this preserves is we do have a large team dedicated to maintaining our own guidelines across all of our programs, collaborating with professional societies and other outside experts to make sure that we're doing the best job we can, keeping the evidence as current as possible. And we also have an ongoing stream open for feedback any time of the year through our website for people that want to submit changes to the request for change to the guidelines. So that gives us a speed to the correct decision on the cases where you do submit records. So it reduces our administrative burden, but the benefit of that primarily is that it speeds the time to decision for everyone on this call. So where's clinical decision support kick in? Clinical decision support is really about just highlighting the evidence. And saying, here's what the evidence says. Do you want to run this against your professional society and see how this runs against the evidence to make sure we don't have a blind spot. So we've done this. Our radiation oncology program just transitioned this year, and so they had historically used what at the time was a relatively efficient form. It was a relatively short form, but it asked a lot of clinical questions. And to help them identify what the details were around the cancer, and then what type of radiation treatment was going to be used, and some of those might have been as long as 20 questions. And in looking at the data and in looking at utilization patterns, they realized there was an opportunity to do it better. And so using some of the data that's already in the system around the patient's diagnosis and some of the other things with their history, they realized there were certain areas where we could reduce the questions substantially, down to 3 or less, which is a huge reduction in clinical questions. So that you can, once we have those key things identified, we can identify you're making an aligned decision quickly, get the approval, move it along. It aligns the radiation oncology program with the way the medical oncology program has been running since its inception, which again makes this better and faster, easier to court, easier to log, and it also puts some really key infrastructure in place for some longer-term enhancements we're looking at around being able to look at a broader episode of care in one bite around authorizations. So here was an example of a list of questions, and we have the extreme example where we have one where really it's there's a lot of different options for radiation and not too many that would not receive any. So they just, once they realize what the diagnosis is, they can drill right to what's the preferred approach and get things done very, very quickly. So speed up just a little to keep an eye on time here, and really importantly also is automating the administrative tasks. And this is a really exciting area where we're starting to get done many years and many dollars of work directly with provider groups, directly with EHR companies, getting connected so that we can really get on a path toward extracting data and even removing manual entry that's required today. And I'm going to let Jonathan take us through the detail here, because this is really, I don't want to steal his thunder on this part of the presentation.
Sure. Dr. Gratias, before we jump into that, some questions are coming in. One of the questions is, what other modalities will the eviCore and telepath be introduced in the near future?
Yeah, we're doing radiology this right now, so we're going to get through all of the radiology work first, where that's going to deploy, and we're considering 3 others at this point, but we have not made a decision about what comes next of our other programs.
Okay, great. And one other question: do you use NCCN guidelines?
We do. They're a critical strategic partner for us. We actually work closely with them. Our decision support algorithms for medical oncology, for example, are actually developed collaboratively with NCCN, because we want to be sure that we're getting those right. But our radiology program, our radiation oncology program, and our lab program all also use NCCN guidelines as one of the sources. With those other programs, there are other professional societies that are also producing high quality evidence that we need to consider alongside it, such as ASTRO or the American College of Genetics or the American College of Radiology and others. So yeah, but NCCN is a very important strategic partner for us in the oncology space.
Great, thank you. So we wanted to spend a few minutes today talking about how we're also automating and simplifying the administrative side of the prior auth process. Our research has shown that probably about 2/3 of the prior auth process is actually building the case. So it's going in and entering the patient demographic information, ordering provider, rendering provider, ICD, CPT, yada, yada, yada. And so what we have started to roll out, it's in its early stages, and we're starting to expand it pretty quickly here, is actually leveraging the EHR to automating that entire case build process. So how it's working today is that the EHR, when a procedure gets scheduled, in some cases it can be configured to when it gets ordered, either way, but once that procedure, that triggering event happens, that the EHR then packages up all of the information. So for example, it's looking at the CPT code. So if an MRI of a lumbar spine gets ordered and it's for a certain health plan, then the EHR will package up all of that patient information and case information and send it over to eviCore. Once it hits eviCore, we go through a number of steps. The first step is actually checking to see if a prior auth is required for that CPT code. If it is, we then do a quick eligibility check. Is this patient still a member of Health Plan X? If it is, if they are, then we move that case along to the clinical adjudication process. And we leverage a lot of the technology that Dr. Gratias just mentioned a second ago. So for a subset of those cases that get approved using the AI or advanced analytics, the authorization information and all of the other relevant and pertinent information then gets sent back to the EHR. So it truly becomes this bi-directional round trip, which is touchless. What we've seen where this is being deployed is that entire round trip takes about 23 seconds. So it's really great from a provider's workflow point of view. In most cases, that there's a work queue, and as soon as that procedure hits that work queue, within 23, 30 seconds later, up pops the authorization information. So for all intent and purpose, we are automating or eliminating all of the prior auth process for about half of the cases. And then the other half of the cases, the provider just simply needs to manually upload the chart information. And again, we're pushing for those cases that are not immediately approved. We push back the status of that case. So in this case, it would be pended, needing additional clinical information with the case number. So today, the provider would manually upload the chart information, but we're actually testing out in a number of provider locations is that we can leverage enhanced connectivity to have the EHR electronically send us back the clinical information. So in this case, for the 50% that would be approved, they would just disappear. And then the other 20, 30%, we would receive that clinical information, and our clinicians would then again use that technology to find the supporting evidence and approve those cases. So our hope is that we believe that we can automate roughly about 80% of the prior auth requests. So it's that last 15% that Dr. Gratias shared a second ago, where we would just need to have more of a clinical discussion. So that's how we're trying to automate the process as much as possible with EHR connectivity. Dr. Gratias, did you want to add anything to that?
No, I think Jonathan described a process that made it sound really elegant and simple, and it is. But as I've learned from working with these great innovators, there's a lot of very nuanced, detailed work behind the scenes getting to that point, and we're not done there. So what's sort of the next? Do you have a sense yet, Jonathan, for what's the next big hurdle for us on this, where practices can start really feeling benefit?
Yeah. So one of the questions that we get a lot that's coming in is, what's the level of effort on the provider side to achieve this touchless process? So the good news is that we eviCore are actually leveraging industry standards. So for example, like the EDI X12278, as well as other connectivity tools like Fire API, the Epic App Orchard, and then I know that there is another large initiative that we're working on called DaVinci Fire. And so these are ways that provider organizations and health plans and eviCore can all share data very seamlessly, both the demographic information and the clinical information. So by leveraging these standards, we can actually simplify this connectivity and accelerate the implementation time significantly. One health system that we worked with told us that they only needed about 25 hours to configure their EHR, and that was Epic, to be able to send us a 278 for us to have this bidirectional round trip. So not a lot of heavy lifting that we understand on the provider side. Obviously, all resources are very strained right now, and we understand that. But we that's one of the reasons why we did not want to have a very overbearing solution to go into the EHR. We wanted to leverage EHR technology to get this turned on and get it scaled up. And the other good news is that eviCore's goal to reduce that prior auth burden is that we're making this connectivity, this touchless, this technology free to the providers. So really excited to be rolling that out to help providers reduce that time, money, and effort for the prior authorization. I know we're just under 5 minutes, so we might want to keep going.
Yeah, and so there's a couple of questions that have come in. I want to just respond to really quick. One, there was a question around what's the timeline for providers to respond to a validation request. And I'm really glad that was brought up because that's something I want to make sure everybody understands. For us, one of the number one areas for avoidable administrative burden is those cases where the result of the prior authorization is an approval of the original request, and the reason it wasn't approved right away and went through steps of holds for information or peer-to-peers or even denials and appeals is because we didn't get the correct clinical information. It's frustrating for the providers, it's frustrating for the health plans, it's frustrating for the employers, it's frustrating for the patients, it's frustrating for us. So these automations are designed to help reduce that when we can start to pull that, but I would say that the best answer is as quickly as possible. But I will add the allowable time frame before we have to make a decision is not something that's under the control of eviCore or even largely the health plans. Increasingly, that's becoming legislated to us by the states, where they basically say if you have to make a decision within 72 hours or 7 days or 14 days. CMS has their own regulations. State Medicaids have their own. We sometimes even have employer groups that have a you are paying the bills for the insurance that have a required turnaround time. So there's a lot of complexity there that's wired into the system that does it. So the short answer is, best information as quickly as possible helps everybody, understanding that that's a burden. We're trying to make that easier. Another one that I wanted to address really quickly is slides indicate that 15% of cases are going to physician review, and some specialties are seeing higher. I would say let's not confuse physician review with clinical review. So for eviCore, physicians are the last line. If one of our physicians is looking at it, that means that we couldn't find any reason to say yes to that sooner in the process. Our AI couldn't do it. Our clinical decision pathways couldn't do it. The clinical expertise of our first-level reviewers couldn't do it. So the percentage going to clinical review is higher than 15%, but physician review is relatively low across the area. So there was a follow-up question there about what steps are being taken to identify specialties more highly impacted. We actually don't see it very differently from specialty to specialty. It's relatively standard. We see individual provider groups and systems that tend to be outliers in one direction or the other, and we have a really great provider engagement team that works with individual health systems on that. So at the end, we have a place to submit for questions. So if anybody's looking for more individualized help, we have a mechanism to help provide that to you. So we're
Yep.
Yep, that's why. Yep, this is we're getting there. So this is our key takeaways. Okay, what we're trying to do here is get to yes. Our goal in engaging in this process is to get to a yes. It's not that the patient doesn't need care; it's what care does the patient need. So we want to get there. We want to get to yes faster. We want to phase out the clinical surveys for the provider offices. Let our internal clinicians spend the time on those where needed. Use artificial intelligence every place where it's making the right decision. Getting to yes faster by using these clinical decision support levers, and getting to yes immediately by making it touchless, finishing off our work on the HR connectivity, showing that CDS tool in the physician's work stream so the physician never has to stop what they're doing and move it forward. Key takeaways are about getting to yes and getting to yes faster. So, everyone can read the slide here, but I'm going to say it anyway because I think it's important. But what our goal here with the IntelliPath solution is we're looking for appropriate care today, powered by real-time data for an accelerated tomorrow. It's about time, your time, our time, the patient's time. We want to spend our time wisely and don't spend any time we don't have to. So we'd love to hear from you. We've got an email box that you can, if you have any follow-up from this, any questions you'd like to pose, any individual outreach you'd like, simple email address to remember, connect@eviCore.com. We usually get a higher volume of these after a webinar like this, and we have a really well-attended webinar today. So if we're a little bit slow to respond, please bear with us. We're going to we will answer every query, and we'll do it as quickly as possible. But I just ask if we don't get you in a matter of hours, bear with us. We expect a decent number after a webinar like this. And I just want to thank everyone for their attendance and give you a preview. This is, if you want to learn more and go deeper on some of our automations and AI solutions and how we're going to get this better, we have an upcoming webinar in September. Be on the lookout for an invitation on that. And you're going to hear from Jonathan, some of the IntelliPath team, including Dr. Sid Govindan, about really getting in the weeds about how some of this works. And it's really, really cool stuff. So I'd encourage you all to attend. So Jonathan, back to you.
Perfect. Thanks, Dr. Gratias. So this concludes our webinar. This webinar was recorded. If you're interested in viewing the recording, please let us know in your post-webinar survey. Please remember to register for our upcoming webinars. you will receive an email invitation with the opportunity to do so. Thank you again, Dr. Gratias, for sharing your expert knowledge with us today. Thank you all for your attendance and your insightful questions. And this concludes our webinar. I hope you have a wonderful rest of your day.